bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, which is the Canadian Association of Pediatric Health Centres. And today we're going to be talking about the pathway through mental health care, the complete and comprehensive school approach. And it's a great pleasure to welcome Dr. Stan Kuchar back to our CAFC Presents stage. He was here with us about a year ago when he came to us with a presentation that was titled, "What Role Can Schools Play in the Pathway to Youth Mental Health Care?" And now he's back to give us a bit more about this topic, again focusing on that intersection and collaboration of health and education sectors as important players in this challenging issue. And that presentation, the previous presentation, is available on the CAFC Knowledge Exchange Network at www.can.cafc.org if anyone wants to go back following this and have a look at that one. So it's my pleasure to introduce Dr. Stan Kuchar, who is an internationally renowned expert in adolescent mental health and is also a leader in mental health research, advocacy, training, policy, and services innovation, working at the IWK Health Centre and Dalhousie University in Halifax, Nova Scotia. He's also the Sun Life Financial Chair in Adolescent Mental Health, and he's also the Director at the World Health Organization Collaborating Center in Mental Health Policy and Training. So certainly an expert in this area, and it's my pleasure to hand the virtual podium over to Dr. Stan Kuchar.
Thank you very much, Doug, and thanks to CAFC for hosting this webinar. And to all of you who have joined, thank you very much for participating. And I hope that today what we will achieve is to be able to think critically about what we are doing to enhance mental health care for young people, and to once again reinforce how important it is that we bring together those institutions which we have developed to serve our children. So first I'd like to just thank everyone on my team for their help with the work that we're doing, and special thanks to Minna Hashish, who prepared many of the slides here. I'm starting out with Pogo. Some of you will remember Pogo, one of my favorite comic strips, because we're going to come back to Pogo and one of the most famous sayings from this comic strip at the end of the presentation. So something to be excited about. What did we learn from Pogo? I'm going to start off with the semantic confusion. Some of you have maybe heard me speak about this before, but it is a frankly big problem in our field. We often obfuscate when we speak with each other, when we use such terms as mental health issue. We don't know if we're talking about a temper tantrum or a schizophrenic psychosis. We use concepts like mental wellness. We're using the word mental wellness to mean mental health, which is simply an extension of the same concept. However, it has tremendous marketing cachet. If you don't believe me, just look up wellness underwear or wellness muffins or wellness music or wellness water, and you'll see what I mean. And now we're getting to some really interesting machinations of these phrases. I recently saw one on Twitter where an organization in Canada who should know better was talking about mental health unwellness, which of course is really getting us all confused. So The triangle, I'd like to just remind us, is probably a good way of thinking about this. Mental distress being a ubiquitous, common, normal response to the exigencies of everyday life. Mental health problem being, again, a normal response to substantive stressors, such as the loss of a loved one, loss of a job, major problem occurring in a school setting. And a mental disorder or illness being that diagnosed mental disorder that requires professional intervention. Clarity of the language is so important. Mental distress, mental health problem, and mental disorder. When we use the same term for every one of these three domains, it's very difficult for us to know what we're talking about, and it confuses all of us. And as you'll see a bit later on, it confuses young people in the schools, because if they use the term depression when they actually mean they're unhappy, then the solution or potential solution to that is to seek treatment when that is actually what they do not need. And being clear about the categories really helps us direct the interventions that we want to have in our schools, in our communities, in our homes, and in our health system. So promotion is important, building resilience. With mental distress, we build resilience by avoiding protection from everyday stress. One of the major challenges that we have currently in our school system is the propensity to try to snowplow all stress out of the way of students, which in the long term tends to lead them with learned helplessness and the inability to address the slings and arrows of outrageous fortune. Mental health problems, a greater magnitude of environmental stress, or here, enhancing supports, counseling services, additional supports in the schools, absolutely really important for young people. They don't have a mental disorder, but boy, they can sure use some help. But it doesn't have to be of the high intensity of psychiatrists, psychologists, and those other kinds of health providers. Really good enhancement of supports in the school system meets the needs of these young people very well and very effectively. And then for mental illness, what we really want is rapid access to best-in-class care. Just to remind ourselves that the 10 to 15 years following the onset of puberty are those associated with mental disorders. I'm now talking about that top part of the triangle. And in this period of the lifespan, the vast majority of mental disorders can be diagnosed. And we know that 70% of all mental disorders can be diagnosed before the age of 25, which means that since young people are often in school settings, that the schools are an actual not good place to start with identification of young people who may have a mental disorder, but a necessarily essential place for that to happen, because after all, that's where the kids are. This next slide shows the disability-adjusted life years due to all mental disorders across the lifespan. So not only do mental disorders onset during this period, this 10 to 15 years following puberty, but their impact over the lifespan is actually the greatest during this period. So again, showing us the necessity for early identification and rapid access to effective care for those young people who actually need that. And we know that in this age group, when mental disorders onset, many are mild to moderate in intensity and respond very well to stepped care approaches, low-intensity interventions, which then can preserve high-intensity interventions for those young people who are presenting with severe illnesses also at this age group. Now, this next slide is a bit of a wake-up call, a bit of a reality shift, and it looks at the relationship between the health status in a population and the cost of interventions provided to them. What I want to draw your attention to here is the dotted rectangle on the right-hand side of the curve. You see a amount of resources being put into a population, but it hardly changes the health status measurement at the top of the curve. On the left-hand box, you see the same amount of resources being put into a population when the health status is low, and you see tremendous improvement in the health status for that same cost. What this means to us is that when we invest in populations that are already very healthy, that we are hard-pressed to see any substantive improvement on our investment. However, when we invest in populations whose health status is not very healthy, we see huge improvements and huge return on our investments. So young people with a mental disorder are in that category who have a health status that requires investment and actually brings a good return on investment. Investing in wellness enhancing and optimizing mental health, frankly, does not bring that huge return on investment because most of the people who are being given that intervention are in a quite healthy status already. So we have to think critically about how we're actually investing our dollars and what we expect to get for the investment that we have. The next slide really shows this comprehensive pathway to mental health care, all the different components that are part of that pathway. And you'll see it starts with the family and the family situation, and there are families in which this pathway to care can start with adequately and well, and families which require additional supports for that to occur. We're not going to be talking about that today. The primary health care provider is the cornerstone of mental health care, or should be the cornerstone of mental health care, just as they are the cornerstone of all health care in this country, and in fact in most countries in the world, in the Western world. However, schools, and this is again an issue, and this is what we're going to be talking about, schools, what is the role of schools in this pathway, and how can they link with community access points, which is what CAP stands for, and also with specialty mental health care and primary health care, in order that we can actually meet these mental health care needs for the young people who actually mostly are in our schools. In a more simplistic way, this next slide shows the horizontal integration of this pathway. It starts with mental health awareness, proceeds to mental health literacy. The next component is identification, triage, access, and support for young people who need the interventions. And the final one is the provision of effective, best evidence-based care. Now, mental health literacy is the second component. Mental health awareness is the first component. Very often we have been focusing so much on mental health awareness that we forget that it's only the beginning of the journey, not the end of the journey. So mental health awareness can have many positive outcomes, but also if mental health awareness is not paired with mental health literacy, as we will see in a minute, it may have less than positive outcomes. So mental health literacy is essential for that movement from awareness to knowledge, understanding, and then further along the pathway. It is the next step on the pathway from mental health awareness. It's moving from let's talk to let's talk smart. The next slide shows a graphic from our Pathways to Care video, which is on our website, and it points out that traditionally schools and healthcare have existed as separate systems, and that these systems have tended to be siloed. Now, in some places there have been breaks in the silos, but really most of those breaks have been in the metaphor of bridges or pathways rather than integration within the two components. And what I will be arguing here and showing you hopefully is that if we really want to improve health outcomes and mental health outcomes for young people, the approach to this is not to maintain the silos, but the approach to this is to integrate interventions where the young people are. What I'm sharing with you, I would like to think is relatively new, but unfortunately, it's not as new as I would hope it would be. The World Health Organization in 1994 published this report called Mental Health Programs in Schools by Hendren et al. If you haven't read it, I would really highly recommend that you read it. It sets out a really useful paradigm, framework, model, strategy, suggestions for addressing the wider issue of mental health in schools, and some of the things that I will be talking about today are already mentioned, well described, and suggested in this document. So pretty well should be essential reading for most of us who work in schools and most of us who work in mental health. Back to this pathway framework again, we're going to now focus a little bit on mental health literacy. We know from the World Health Organization that health literacy is, and I'm going to read this slide, quote, a stronger predictor of an individual's health status than income, employment status, education, and racial or ethnic group, end of quote. What that says is that while there are many and very important social determinants of health, health literacy is an independent and very strong determinant of health. We need to address poverty. We need to address social inequalities. We need to enhance inclusion. All those things are social justice issues. They are necessary, but they are hard to do. And while we keep focusing on and working on them as we should, we really can't ignore the low-hanging fruit, and that is enhancing health literacy, and in the mental health side, enhancing mental health literacy, because if we do that, we can actually get started on the path that we need to be on. So what does mental health literacy mean? Well, it has 4 different components. These have to be approached in a developmentally appropriate manner. So the way that we do this in primary grades is different than the way we do it in junior high and secondary, which is again different from the way we do it on campus. But all 4 components must be there. One is understanding how to obtain and maintain good mental health. Also understanding what mental health means, and to understand that you can have a mental illness and have mental health at the same time. These are not constructs on a continuum. We don't move from health to illness. In fact, most people that I know, most people that you know that have a mental illness actually have good mental health concurrently. We have to be able to understand and identify mental disorders and their treatments. And here the key word is understand. It's not memorizing lists of signs and symptoms and, oh my gosh, I have that symptom, therefore I have the illness. No, it's understanding the illness, having a deep knowledge of the illness, and also a deep knowledge of the purpose and types of treatments that can be helpful. Decreasing stigma, really important. And what a better place to decrease the stigma than integrated into everything schools do. Not one-off events in schools, but integrated in what they do every single day, every day of the week, every week of the year when kids are in class. And to enhance help-seeking efficacy. Know where to go, know when to go. Very important to know what to expect when you get there, and to have some competencies, which you can learn in schools. Competencies which will help you get better care because you can interact in a more informed way with your care provider. And mental health literacy is limited. It's a concern. Recent data shows that less than 50% of adolescents can identify depression as the mental disorder, and more concerningly, perhaps, is that they confuse depression as a disorder with depression as feeling unhappy. So difficulty in knowing where the normative components of negative emotional states are compared to where the components of a mental disorder are. Less than 25% of adolescents can identify an anxiety disorder, but again, we have the same challenge. Many adolescents use the word anxiety when they mean stress response. Many adolescents use the word stressed out or overburdened when they are dealing with the normative components of life, and therefore rate themselves as having anxiety when they actually are dealing with pretty normal stresses. The average mental health literacy score out of 100 in a paper we're just now submitting for publication was 30%. This was hundreds and hundreds of teachers from across Canada in multiple provinces. There were no differences among provinces, but this tells us that the average teacher in the average Canadian classroom really has a lot of mental health literacy learning to do before they start to teach mental health in classes. As I was saying, this is one of the unfortunate outcomes of lack of mental health literacy, the inability to separate out normative stresses of life from the components of mental disorders, which are potentially anxiety disorders or potentially depression. This really interesting article in Atlantic, which I would highly recommend people reading, focuses on defining depression as a fad or a fashion as opposed to a mental disorder. How confusing can things get for kids? Is it fashionable to be depressed, or is depression actually an illness that needs treatment? And to make things even worse and more complicated, this is a recent study conducted by the Mental Health Foundation in the United Kingdom, which shows this confusion dramatically. Here they report that 43% of people in the United Kingdom have depression. This is complete stuff and nonsense. That's just completely not possible. The actual percentage of people in the United Kingdom have depression is about 8, maybe 10% of the population. What's happened here is that they have used self-reports of negative emotional states to be equated with depression. And this is a challenge to us, because if we are using the language of pathology to pathologize normal life experiences, this is a huge concern. It means that we overreact to the normal slings and arrows of outrageous fortune, and it means that people who need access to care often can't access it as rapidly as possible. What we are doing is confusing unmet need with met unneed. Our approach to this, some of you may know about it, is to actually embed mental health literacy into school curriculum, developed for grades 8 and 12, so that both students and their teachers, and this is so important, that both students and their teachers will develop mental health literacy through regular curriculum exposure to these core concepts that we just talked about. We also enhance capacity in the schools for identification, support, triage, and referral by a go-to educator program in which teachers that kids naturally go to when they have a problem learn how to identify young people who are at high risk for a mental disorder, link them to the appropriate student services provider in the school, and then support the rest of the journey within the components that are appropriate for the young person in the school setting. It has 6 modules. It is all freely available online, and within 4 months we will actually have it available as a complete online learning course for any teacher in Canada to freely access under the online learning rubric of the Faculty of Education of the University of British Columbia. So look for that, because it should be out in October, November. And the data shows us quite unequivocally that this works. It works in the short term, it works in the long term, it improves knowledge dramatically, decreases stigma dramatically. These improvements are sustained over time, and it improves help-seeking behaviors as well. The brand new data we just obtained last month, a huge study in Newfoundland showing that this is for student services providers. So these are counselors, school psychologists, educational psychologists, social workers working in schools. Huge, significant, and substantive improvements in knowledge from exposure to the go-to training program. Improvements greater in people who had less knowledge when they started, which was good, and also significantly improved attitudes. That's decreased stigma. Again, much greater in those people who had poor attitudes when they began. This kind of intervention actually works and is a sustained working. Very interesting study also recently published by Dr. Carr from the University of British Columbia, which this intervention was given to a cohort of pre-service teachers. And what you see from this table is significant improvement in knowledge, decreased stigma, and help-seeking intent that occurred right after the intervention, but also showed substantive continued improvement in 3-month follow-up. So doing what it's supposed to do. And actually some brand new data from Calgary. This was presented at the CAPAP conference last year. As the go-to intervention is rolled out through the schools in Calgary, those schools in which they have go-to teachers trained, young people are identified and triaged and moved into Alberta Health Services care in a way that is just not possible, is not happening in schools that are untrained, and compared to what those schools were like before the training occurred. So a really nice example of early identification and then access to mental health care. So now the question becomes, what do we do if we've done the identification, triage, and access, and how do we get the evidence-based care available for young people? And we need it. This sky-high data shows us that although mental disorders have not changed in prevalence, that we have increased numbers of emergency visits, we have increased numbers of hospitalizations for mental health concerns, and that is all rising while the other hospitalizations for other conditions has actually decreased over time. Some of this can be attributed to the increased awareness and better identification of young people that have mental disorders. Concerning is that the emergency room is being used as the portal of entry to the healthcare system. And looking at the hospitalization numbers, one is concerned that young people are waiting until conditions are very severe before they actually access care. We don't want that to happen. So we have to look at providing mental health care in primary care for children and youth. And so now I'm going to switch towards the primary care component, and we will come back to schools because we can see how primary care can be embedded in the schools as well. Again, the primary care, mental health care is not new. This World Health Organization Wonka report from a number of years ago really showed that the way forward globally for enhancing rapid access to effective care for most people was to embed mental health care into primary care, so that when an individual had their first touch with the healthcare system through their primary healthcare provider, they would be equally able to access care for depression, anxiety disorder, ADHD as they would for acne, substance difficulties, diabetes, or arthritis. It's important to note that mental health care should be readily available everywhere in primary health care. Unfortunately, it's not yet, but it should be. And the reason for that is that more people can access the care, because many more people can access primary health care than can access specialty health care. Primary health care is the foundation of our healthcare system. It is the building block that all of healthcare is created from. It's also the point where healthcare, health maintenance, health promotion, and disease prevention come together. So it is the perfect place for addressing mental health care needs, because we can address all these different components of mental health in addition to mental health care. Primary health care is developing and improving, and it's developing into coordinated multidisciplinary teams with evolving scopes of practice, so that various different health providers now work together. And so we can bring counselors, we can bring social workers, we can bring nutritionists, occupational therapists, nurses, and physicians together and create a primary health care team which can actually meet mental health and healthcare needs of young people in the same spot. So primary health care is really the central component for what we call integrated care delivery. It is the component of our system that already exists. It needs to be improved. And the data show, this study by Honigfeld, for example, showed that primary care providers play a larger role in the care of children with attention and mood disorders than any other professional. So if young people are already going to primary care providers, shouldn't we ensure that the health care needs that they have can be appropriately met in primary health care? And there are lots of different models that we can look at. Co-location models in which mental health specialty services are co-located in primary care community centers. A community hub model in which the actual mental health services are more integrated into the primary care services, but also in which other services, education, social services, justice, etc., can be in the same place. And the chronic illness model that you may be familiar with, that Wagner has written extensively about, which is really appropriate to mental health care because most mental disorders are chronic disorders, and they really need that chronic care framework for optimal outcomes to occur. In order for these to happen, though, we need to address something called task shifting. And what that means is that primary healthcare providers, many of them, although well-intentioned and well-meaning, have not had the necessary skill development and competency development to be able to provide the kind of care that is needed in primary healthcare, nor, and this is important, have all primary care facilities managed to develop these multidisciplinary teams that are really needed to enhance the capacity in primary healthcare. So these competency enhancements have to be done through training, and they also can be achieved in some degree through the provision of collaborative care, which has the added advantage of providing ongoing consultation to primary healthcare providers. An excellent report, I just think it's wonderful, from the Ontario Centre for Excellence for Child and Youth Mental Health. Those of you who are interested, looking at many components of primary healthcare and how to address primary healthcare. What are the barriers, what are the challenges, what are the opportunities for doing this in a rational way in Canada? And that report just came out this year. However, some places have been doing this already and have been doing it actually rather well, so that our challenge is not that we don't know what to do or we don't have to reinvent the wheel, but maybe we should look to places that have been doing this and see what we can learn from them, both in what could be done better, what could be improved, and what works, and how can that be applied. So the Physician Support Program of the British Columbia Medical Association, about 6 or 7 years ago now, developed an intervention in child and youth mental health and primary care, which has been very successful. They've taken a local team model, which brings school personnel together, ministry personnel, family physicians, families, patients' families, specialist physicians, and puts them into this team, a multidisciplinary team, and then they develop the interventions and approaches that meet the needs of young people and their families. And they do it in both school settings and primary health care locations in the clinics. Some of the training outcomes from independent evaluations show high satisfaction with primary care providers, incorporation of what they learned into their practice, and the patients and the parents of patients are more satisfied with the care they get. 95% reported that the care improved. 80% actually reported that they were using non-medication interventions first. So mild mental disorders or difficulties were being effectively treated with non-pharmacotherapies first, which is a good thing. We use medicines when we need them, not when we don't need them. What we see here also is this approach significantly improved school collaboration and, interestingly enough, improved collaboration with mental health specialty services. And a whole host of improvements occurred in practice. Clinical screening was better, case identification was better, diagnostic comfort was better. When they did use medications, they used medications in a more appropriate way. So overall, very, very useful kind of intervention that we already know can work in primary health care. Another variant of this was done at Queen's University, and Dr. Khalid Khan published on this, showing with a simple one-day training intervention, knowledge improves quite dramatically in primary care. Providers' comfort with diagnosis and treatment improves, and I think this is the most important slide, is that referrals by primary care physicians to mood and anxiety clinics decreased by 1/3, and referrals to urgent consult clinic changed from common non-comorbid disorders to complex, moderate to high comorbidities, which means that the primary care providers were now providing effective care in primary health care to young people with low intensity, high volume care needs, and we're preferentially referring those young people with low volume, high intensity care needs, which is what we need specialty services for. And Queen's University is now piloting a very interesting project which uses a complete electronic health maintenance record to enhance this interface between primary health care provider and the youth recipient of mental health care. So that's one way that we have been doing this, or could be doing it. Another way is the Standalone Youth Community Access Point, and this has gained popularity in different parts of the globe, Australia, Ireland, and now increasingly in Canada, and it has merit. It's a one-stop shop approach. It has the potential, by the way that they're being developed, to engage some youth in the development and delivery of mental health care. The sites may be more appealing or youth-friendly than traditional primary care settings are, which are not often designed to be welcoming to young people. And I think this next one is a very important point, that they may have greater utility in enhancing access to care for populations who are difficult to serve or marginalized, youth homeless, youth on the street, youth having other kinds of difficulties who wouldn't necessarily be in a school setting or may not be attending a primary care physician's office. And this is a good friend of mine. Steve here is a young psychiatrist who has done tremendous work with him and his team, Steve Mathias in Vancouver, with the Foundry Integrated Youth Services Center. Completely biased here because I think it's a actually wonderful organization doing wonderful work, and it really focusing on young people in a difficult part of the city. And here you see another picture of the center. Recently had privilege to have a great tour of the center. Thought it was doing good stuff. And in British Columbia, they will be expanding this concept to other places. Now, this model was applied in different kinds of settings. In Australia, it's called Headspace, and there it was applied, not as Steve has applied it in a high-needs population, but was applied overall. And now the data is coming in on this standalone center, and unfortunately, the data is not supporting the hype. The center has expanded quite widely across Australia without evidence that they were effective. And now the studies looking at them showed that only 1/3 of youth who came to the centers actually had improvement in their symptoms. Half of them had no change, and a small number worsened. An independent evaluation commissioned by the Australian government shows that the model is not working. Only 13% of clients showed clinically significant improvement, which is not really where you want to be with this kind of intervention. Some concerns that have been raised or suggestions is that almost half young people who come in don't follow up. And the average number of interventions that they get is 1 to 2 sessions, which is usually quite ineffective for addressing mental health care needs. In recent work by Jorm, who many of you know has pioneered mental health literacy, he focuses now on suggesting that schools be the location in which these services are developed and delivered instead of standalone centers. And he has identified a nice phrase called whole of community approach. And this data, the Australian data, again for 2015, in the survey of child and adolescent mental health, shows that schools actually are a place where young people can get help already for mental health concerns, although that they haven't been tasked and supported in doing that, and supported is really, really important. And a current study, this from the same report here, shows that when young people do receive counseling or do receive assistance from the healthcare provider in the school setting, they actually go and they actually develop a relationship, and they actually stay long enough in the therapeutic relationship to actually probably have a positive outcome. Now, remember in 1994, I showed you the report from the World Health Organization. Well, there they wrote it. Health centers located in schools have an important role in supporting better health care, usually provide primary health care services. They're accessible to students. They're accessible to the clinics. They're located in the daily environment of youth. They offer particular benefit to young people who might not otherwise receive help, and they can run hours outside usual school hours, so they can actually become part of community hubs. Unfortunately, the Canadian approach has not identified school-based mental health centers as a essential component of integrated healthcare. The Mental Health Commission 2013 report on school mental health did not mention school-based health centers, and focused on schools in terms of silos as opposed to exploding the silos. So here's a nice graphic, and it shows if you put a community access point into a shopping center, what 10-minute walk, ride, a bus ride from the shopping center, you're going to get that many youth. So access to the community access point can be a problem. So even if the kids want to come, it may be difficult for them to get there. Whereas if you put the same facility in the school, you completely change the demographic. So I call it health for all just down the hall, and young people can readily access those services if they are located in the schools. So the suggestion I have is, of course, a very complex one. Let's put health and mental health services where the young people are, instead of putting them where they are not. So what do we know about school-based health centers? Very good review, systematic review published last year by Baines and Diallo, shows that in school-based health centers, up to 1/3 of all the visits to school-based health centers are for mental health reasons, which is good, robust access. They conclude that school-based health centers provide access and eliminate barriers to mental health services. More on that later. And this is really interesting, that students who had high-risk behaviors are more likely to have sought services at the school-based health center. And this applies whether we look at the data for elementary, middle school, or high school populations. A nice overview by Honigfeld et al. In 2017 pointed out that school-based health centers are integrated into primary health care. They facilitate rapid access to needed care. They're ideal for stepped care locations where the least intrusive interventions can be offered first. They have better referral mechanisms. The referral mechanism is actually in-house, so a student services provider or a teacher can actually refer the young person to the center, which is on-site, which means you don't have to go home and then hopefully go downtown or go somewhere else to get care. It reduces stigma for you seeking mental health care, because you just walk in whether you need contraception advice, treatment for your acne, or cognitive behavior therapy for your anxiety disorder. And because they're on site, they can have easy access for repeated therapeutic sessions, which is one of the big challenges of health centers which are located in the community and away from the school, as we saw from the Australian data. Different studies by Lai, for example, that all show additional benefits. One is that it enhances the relationships between schools, health agencies, and community mental health providers. And that is really important, because some young people require multiple services from multiple agencies, which can be coordinated through a youth-based health center. And that facilitates interagency collaboration, and the data is showing us that it improves the confidentiality procedures so that young people can sign a one-point confidentiality form and then have that used by the different agencies instead of having to go through the process every single time. It improves student and parent engagement, and there are various strategies that centers use to do that, many of them very successful. And we know that it brings together care and promotion, and lots of different very interesting interventions for promotion can run out of youth health centers. For example, drop-in lunches being one that has received some attention, and the data is suggesting that stigma reduction, because now mental health care is not isolated asylum-like from the rest of healthcare, but you just go to the same place. Very interesting piece by Kornblum et al. In the Pediatric Health, a Canadian piece, which I will come back to later, also points out some of the benefits of primary health care through school-based health centers, fewer emergency room visits and hospitalizations for kids in the schools that have these, greater number of health promoting behaviors, including increases in vaccination rates, sexually active females much more likely to use hormonal contraception, higher use of mental health services, which they attribute to decreased barriers. Also, tremendous impact on the school environment with lower absenteeism, higher grade point averages in the school, so that they're having a positive impact on the school environment, and possibly preferentially accessible for young people who are from minority groups or are marginalized. Now, I've put an asterisk beside that because most of that's American data where insured healthcare is a problem, and young people from disadvantaged backgrounds can obtain health services without having the health insurance through the school-based health center, but they can't necessarily get that in the general community. So this sounds too good to be true, and nothing is that good. So let's think about some of the barriers. One of the big barriers to moving in this direction is our tendency to think and act in silos. The asylum model still sits. Remember, the asylum was initially developed to provide asylum for people who had severe mental illnesses because we didn't have treatments that were effective. We now have treatments that are effective, but we've maintained the asylum. We've gone to the mental hospital. We've gone to separate wards in hospitals. We've gone to community mental health centers instead of integrating this with everything else that we do. And for young people, it has to be integrated into healthcare systems, and it has to be integrated into educational systems. Because the systems, education, and health are silos themselves, there's a greater complexity of working across systems than there is within systems, and those of us who are in the healthcare field or those of us who are in the education field know how difficult it is to change within the system. Across the system makes it much more complicated. Some of this complication is due to the way that funding is established and budgets are allocated, and also some of it is due to a lack of effective cross-sectoral frameworks and champions for cross-sectoral frameworks, and frankly, it's different. So what are some of the conclusions about the potential value of school-based health centers enhancing access to primary health care as part of the pathway through care? I'm just going to quote from Kornblum's paper of 2013, embedding clinics within high schools, same works for junior high and probably elementary, offers a promising model for delivering effective and accessible interdisciplinary health care to adolescents. School-based health centers can offer care that is tailored to the developmental needs of this population, demonstrating compelling benefits for this traditionally hard-to-reach demographic. So we're coming to the end of my presentation, and so I said I'd bring Pogo back, and here, of course, is my favorite Pogo cartoon. We have met the enemy, and he is us. The issue being, it's not that we don't know what to do, it's that we have a hard time putting into place what we know. Those of you who are interested in doing further reading on it, we've suggested some references that you might want to look at, some recent reviews of school-based health centers, some information on the assessment of Headspace as a community integrated access point, some more information on Foundry, which I again am biased towards, and access to the great reports from the Ontario Centre of Excellence on primary care. So thank you very much for your attention. And we can open the floor for comments and questions.
All right, thank you very much for the great presentation. We do have a few questions. If we can share the slides that you just presented with the audience, so particularly that slide with all of the references that you just had at the end, I think people would appreciate having a copy. Is that okay if we share the slide?
Oh, absolutely. Everything that we do here is in the public domain, and we encourage people to use anything they find of value.
All right, sounds good. So we will share that with the audience, in particular on the Knowledge Exchange Network following this. And also we had a couple questions about a recording of the presentation. And yes, we do record the presentations, and we will also share those there. The one question that came in was when you put up the example from Calgary. She is asking, the example provided about Calgary indicated an increase in referral rates. She was wondering, what is the accuracy of the referrals? Were those students truly needing referrals? For example, were teachers able to accurately refer those who needed treatment versus the minor stress needs, etc., versus completely unnecessary referrals? She says they hear students and families are often turned away for a variety of reasons that might include a lack of services, but also the youth not being severe enough. So just wondering if there was any indication of the accuracy of those referrals.
Yeah, fantastic question, and here I am very pleased to say absolutely yes. So what I showed you is the data on the referrals, and now this is data from Alberta Health Services. So the people in Calgary were able to link the schools that had the intervention with who went to Alberta Health Services. So it was data on the receiving end, not data on the sending end. And one of the things that from the common data set that AHS has is they do a measure of severity of the disorder related to the referral, and so the researchers there looked at that. And what they found was, yes, exactly what was pointed out. The young people that were coming were moderate to severe mental disorders, and the kids that weren't coming were the mild or not necessary. So that's a good thing, I think.
Yeah, all right. We did have another question about sharing the presentation with their colleagues within their school, and as Dr. Kuchar said, he's more than happy to have his information shared. Our presentations are free and open to the public, so please do encourage all of your colleagues to have a look at this. And you will receive an email on Friday with a link to the presentation and the other resources as well. So please share this presentation as far and wide as you would like. We had a question coming in about just asking how we might be able to leverage digital technology to do screening in school-based settings. Any thoughts on that?
Yeah, I would actually, number one, encourage not to do screening in school-based settings because you always be careful that you may get what you wish for. And I'm just going to tell you the anecdote of the first time that I did this unwittingly, with all good intentions, in about 1987 in the North York school system in Toronto, when we're developing our unit at Sunnybrook Health Center, the adolescent unit there. And we realized we had to go into the schools and start to do some work in the schools. And so we did a whole school screening at 5 different secondary schools in North York. And I can remember about 2 weeks after we had done the screening, my research lead coming in to my office and saying, we have a huge problem. And I thought, oh gosh, we're wrecked up the data, something like that. And I said, oh, what's the problem? And she said 38% of the kids scored above threshold on our screening. Now what are you going to do? So it's a real concern. So population-based screening, we have to remember, it's dealing with positive predictive value of the tool, which sometimes is a concern. What are you screening for? Are you screening for suicide intent? Are you screening for suicidal ideation? Are you screening for presence of negative emotions? If you're screening for presence of negative emotions, you're going to hit something like 50 to 60% of the population, depending how you ask the question. If you're screening for have you had suicidal ideation, you're going to get 14 to 18% of the population. So there's a big difference between population-based screening and being able to identify young people by key individuals in the school setting, which is the go-to model. It's a modified gatekeeper model. So young people are encouraged to go to these teachers if they have a problem. Many of them are chosen because they're teachers the kids naturally go to when they have a problem. And so kids are then educated, and that's where the literacy component comes in, about what are the potential problems. And so then we're using the education model, the gatekeeper model, to actually help us funnel those young people who have difficulties into treatment that need it. And then the whole total-based school screening, it just opens up a Pandora's box of problems.
right. So a couple questions here about sort of that younger age group, the K to 8 group. Harry's asking if there's a mental health curriculum for elementary schools like the one coming out in October, November with the 6 modules for high school. And I believe Harry is in Manitoba, so I'm not sure if that's a provincial initiative or not. And she's also asking, where can the K to 8 schools start with regards to improving mental health literacy for students? Is it ever too early to start?
Sure, good questions, essential questions. First of all, the mental health literacy curriculum for grades 8, 9, and 10 is already available. It's online. It's free. It's on teenmentalhealth.org. The new version of the updated version of that will be online at the end of this month, and then the e-learning platform with the entire training course that it's free of charge teachers can use anywhere will be up and ready in October, November. So just to clarify, we already have something that's freely available online. But it's just not in a learning platform format at this time. The issue for younger grades, social emotional learning, there are a number of social emotional learning interventions which have some good evidence of effectiveness. There are also many that don't have good evidence of effectiveness. So choosing a social emotional learning intervention that has demonstrated good levels of effectiveness, such as a good behavior game, for example, PATHs, may be really a useful way to put into the primary grades. There is one curriculum piece that I am aware of called Healthy Minds, Healthy Bodies, which is in the Nova Scotia curriculum resource list. You could probably get that by contacting the Department of Education in Nova Scotia. I don't think it's ever too late. I think what is really important is that the mental health interventions be developmentally appropriate, so that the way that we approach mental health literacy needs for junior high and secondary school students are different than for primary students, and those as social emotional learning interventions and approaches are probably much more appropriate for younger ages. When you start to get into grades 8, 9, and 10, we have to change the way that we use these interventions. And then we get to campuses, again, we have to change the way that we use these interventions one more time. I think the key thing here, and the thing that we're trying to do with our partners across the country, is to embed the capacity into the school system. We want to avoid programs. We want to avoid come and learn about this. We want to avoid take this program and put it into your school. What we want to do is we want to use the concepts of frugal innovation, sustainability, capacity building, by bringing capacity into schools. The most important resource that schools have are their teachers. We want to enhance the capacity and competencies of the teachers and other providers in schools, and then that capacity and competency stays in the system, and it's not dependent on things being parachuted into the school setting. So a really important approach.
All right. We had a couple of questions related to when you mentioned the Foundry model. The one person is sort of identifying that you've talked very positively about the school-based model and the importance of that, but Foundry is not a school-based model. And then someone else is mentioning that they work at an alternative education school in Prince George, British Columbia, and they have a Foundry site that's opening up here in August. Her comment is that they still believe that more on-site services are available to our students. So can you just give us, put into context sort of the Foundry model versus the on-site, like the school-based model, and how we can reconcile those two?
Well, I think that the Foundry model is a really good one, and the population that it serves may not be easily served in the school setting. So I think that what we need to have is the capacity to use community access points wisely. And I have tremendous respect for Steve Mathias and the work that he does. Putting a Foundry model into a school makes good sense to me. A Foundry model in a school basically is a school-based health center. That's what it is. In the community, it's a community access point. So my point here is that what we need to do is to bring the services to where the kids are. If the kids are in a community and it's difficult to reach them through a school or difficult to reach them through primary health care settings, by all means, let's put up a structure in which the kids can come to, because it facilitates that access. If, however, the kids are in the school already and that's where the kids are, to me, to put another access point in the community where the kids aren't, you're probably better use of your dollars to put that same access point in the school where the kids are. And the other thing with that is that not every school needs that huge comprehensive approach of every single piece. Some schools, depending on the size of the school, depending on the population, we can tailor the services provided within a school-based health center to the needs of the school, which makes it a very flexible and dynamic approach, as opposed to trying to put every single service into the same location. Hopefully that helps.
Yeah. All right. No, I think it does. I think it's a good point about the two different settings and different needs based on the community, for sure. The next question is asking about the post-secondary setting. She's saying wellness clinics are burdened and functioning over capacity, and she's just wondering, are there successful examples in the university settings of managing that challenge?
Hopefully we will have one in 2 years, because we are right now just starting a study where we're taking on that challenge, and it's a real challenge. I completely agree. Huge demand for care, and we're finding that it's a lot of that is what we would call maybe unmet need, but nevertheless, people feel that they need the help. So we have to start at the beginning and start actually with the literacy component, developmentally appropriate literacy. One of the components is to help people differentiate these normal stressors and the stress response from mental disorders, and to also focus on developing some of the life skills and life competencies that people need at that point in time when they're supposed to become much more independent and able to handle many of these things on their own, often for the first time. So we actually have a project with 6 or 7 campuses in the Maritimes, in the 3 provinces, New Brunswick, Prince Edward Island, and Nova Scotia, which brings universities and community colleges together in a cluster-controlled study, which we are engaged in right now. And within about 2 years, we should have the data, and then maybe I'll be able to answer that question. But right now, it is a problem. We recognize that, and we're trying to fix it.
All right. Annie's just making a comment that in New Brunswick they have an integrated service delivery model in schools, and she thought it may be interesting to add that to your excellent presentation. We do have one more question. The question is saying she's the pediatrics support teacher at UHNBC. I believe that's Northern British Columbia. There is a huge gap in the continuity of care between schools and Northern Health, which is the health region, I think, in that area. She says their numbers show that the number of students admitted under the medical service of psychiatry has doubled every school year since the year 2014-15, or the 2014-15 school year. Any suggestions around addressing a community in crisis like that?
Geez, I don't know enough about those communities to say things that may be helpful and not harmful. And so fools rush in where angels fear to tread. I don't know enough of the circumstances, and I think it would be really unhelpful for me to try to weigh in with this complete lack of knowledge, because communities are very different, their resources are very different, the compositions of the communities are different, their carrying capacity, economic carrying capacity, psychological, social carrying capacities are very different. I just really would hate to weigh in on that. I know that there have been some new initiatives coming out of the Department of Psychiatry at UBC, Dr. Janet Davidson spearheading one of those, which is a educational program for pediatricians and general psychiatrists who are working in more remote and rural communities to try to enhance their skill sets and competencies in dealing with young people who may have moderate to severe disorders in their own communities. I also understand that there is this huge challenge of leaving the community to seek services, which can often cause problems in itself. I wish I could be more helpful, but I'm out of my depth on that one.
Thanks for that. As she understands your inability to really provide a response, she just comments on the shocking trends that they're experiencing right now. So the last question that we'll have, and we'll just take one more. I think we've managed to get through all of the questions, but we just have this one more, and then we'll hand it over to you, Dr. Kuchar, for any sort of final sort of key messages you'd like to leave the audience with before we wrap up. But the last question is just around ensuring the mental health literacy of teachers as part of their training before they enter the workforce. Is there any initiatives around that, whether provincially or nationally, to sort of embed that into the teacher training in some way?
Well, honestly, I didn't pay whoever asked that question to ask that question. But now that you asked the question, yeah, there is. In fact, we're almost there. We have been working for 3 years now, maybe 4. Gosh, time flies. With the University of British Columbia, Western University, previously called University of Western Ontario, St. Francis Xavier University, so we got a coast-to-coast distribution, and ourselves. We have over 30 participant observers in the project, which are national education organizations and also the different faculties of education from across Canada. And we have been working on creating a pre-service teachers mental health literacy curriculum. We have worked assiduously for years to develop the curriculum. We have gone through the process of getting modifications from all the participant observers on the curriculum. We have revised that based on those interventions. We have field tested the curriculum in different locations, and we have revised that based on the field tests, and we have just submitted a grant application that we're waiting to hear on to get this entire resource put online and freely and openly accessible to all the faculties of education across the country, but also to teachers who are currently in practice. And a number of these things that we're doing are actually going to be on the agenda of our school mental health academy, which will be in Halifax in on July 20th and 21st, and people are interested in coming and participating in that. We'd be love to have them.
All right. Well, thank you very much for that. And I think we do have some more questions coming in, but I do think we are quite a bit over time here. The contact information that's on the slide, that's on the screen right now, is that the best place to get a hold of you if anyone has other questions or wants to access resources or any of the information that you presented today? Those are the best ways to?
Yeah, I think so.
All right. And with that, I think we'll wrap it up. Would you like to just any key closing messages you'd like to leave the audience with before we wrap this up?
Well, I think it's really exciting that we, when I first started in this work, schools and healthcare were so completely different worlds, and we've been gradually feeling our way to being able to work with each other. And I think we're at the cusp of really realizing that we need to do that, and we're looking at different ways to do that. And any way that we can move this agenda forward together is going to benefit young people and their families. That's good.
All right. Well, thank you very much. It was a great presentation. It really hit home the importance of the collaboration between healthcare and education to address this problem. I think everyone sees that, but you've given some great examples of the how and how to move this forward. So really appreciate the presentation today.
Great. Thanks for the opportunity.
All right. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's great when you attend live, as you get to ask your questions and contribute your comments and really enrich the discussion. But when you can't watch live, we did have lots of questions about accessing the slides and accessing the recordings, so we do record these sessions and make them available after the fact on the CAFC Knowledge Exchange Network at www.ken.cafc.org. Next week on June 21st, we will be welcoming back Sherry Stewart to our podium to talk about personality and risk for substance abuse, the background, content, and evidence base for the Preventure program for adolescent substance abuse prevention. So lots of interest, I'm sure, from the audience today, dealing with that school-based population. Dr. Stewart will introduce the background theory and research that stimulated the development of the Preventure program and will provide an overview of the content and structure of the intervention. And she will review the established evidence base for the program and plans for next steps for that research-based program. And then following that, on June 28th, which will be our last webinar before our break over the summer, we'll be introducing Child Bright, and we'll present an opportunity to get involved in their patient-oriented research network. We're going to have Dr. Annette Maneemer, along with Dr. Stephen Miller, Dr. Dan Goldwitz, Frank Gavin, and Dr. Keiko Shikako-Thomas as they share an overview of the network and how it is currently supported by patient-oriented research, patient-oriented training, citizen engagement, and knowledge translation programs. So it's going to be the first of what will be a number of webinars related to and bringing the research of the Child Bright patient-oriented research network. So as always, some great stuff coming up. A couple more episodes of CAFC Presents before the summer break. But thanks again for joining us today, and we hope to see you back here for the next couple weeks. Bye, everyone.